Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is Mishal Mendiratta-Lala, and today I'm going to talk to you about multiphasic liver mass characterization, and we're going to focus on hemangiomas. So we know that we have an increased use of imaging. Patients come to the ER with abdominal pain or in the outpatient setting, and we're always getting ultrasound, CTs, and MRIs on these patients. This is resulting in increased detection of incidental liver lesions. In fact, 20% of patients have benign lesions, or incidentalomas. It's important for us to distinguish benign lesions from malignant masses. Additional imaging is often indicated in patients with a known background history of liver disease, such as hepatocellular disease or cirrhosis, patients with known malignancy, or symptomatic or young patients, and finally, non-cystic lesions. In order to characterize a liver mass, it's very critical that we have appropriate multiphasic cross-sectional imaging and timing of imaging acquisition. So there's multiple phases that we hear about when we talk about CT or MR imaging, which includes late arterial phase, portal venous phase, delayed or equilibrium phase, and finally the hepatobiliary phase of imaging. For liver imaging, the critical phases are the late arterial and portal venous phase. The late arterial phase occurs in which when the portal vein is enhanced to a greater extent than the liver, usually at 30 to 35 seconds. So as you can see here, the portal vein is brighter than the liver in both of these images, and you can see the aorta is very bright. This is a late arterial phase image. Portal venous phase is usually at 75 to 90 seconds, and this is when the portal veins are fully and maximally enhanced, and you are having antegrade flow in the hepatic vein. So here you can see the hepatic veins have antegrade flow. Now, why is it important to have adequate timing of your cross-sectional imaging? That is because the solid liver mass differential diagnosis depends on imaging characteristics, and it differs in patients with and without cirrhosis. So if we have a patient with solid liver lesion, the first and most important thing we need to know if the patient has an underlying history of chronic liver disease or not, because our differential is going to go down different pathways. Second, we need our multiphasic imaging because you need this arterial, portal venous, and delayed phase of imaging to accurately categorize lesions. So when we talk about a patient with no underlying liver disease, we've got hemangiomas, adenomas, and focal nodular hyperplasia as our three most common benign liver lesions, and we're going to focus on hemangiomas today. So the classic imaging appearance of a hemangioma is that first, it's a non-invasive diagnosis. Let's start with that. The classic imaging appearance, echogenic and avascular on ultrasound, T2 hyperintense, and arterial and portal venous phase, you can see progressive peripheral nodular enhancement, which is centripetal. Enhancement follows the blood pool, so you can compare it to the aorta on each sequence, and those nodular areas should have enhancement identical to the aorta. Here's a patient, another classic appearance of a hemangioma, T2 bright. On pre-contrast T1, it's hypointense. On CT, you can see it's homogeneously arterial enhancing, similar on arterial phase MRI. And on portal venous phase, you can see that it persistently enhances. This is what we call a rapid enhancing or flash filling hemangioma. Again, critical that this patient does not have any underlying hepatocellular disease. And did you notice where the orange arrow is that this patient actually has a second lesion? Light bulb bright on T2 weighted imaging, hypointense on pre-contrast T1 weighted imaging, peripheral nodular enhancement that progresses on your arterial and portal venous phase of imaging. So this patient also has a classic hemangioma. Here's a patient who presents with an ultrasound, and there is an iso to mildly hyperechoic mass in the liver. The patient went on for an MRI. We see this T2 light bulb bright lesion. It is demonstrating homogeneous arterial phase enhancement, which follows the blood pool and persists on portal venous phase of imaging. When you see a lesion like this, your differential could be a rapidly enhancing hemangioma, focal nodular hyperplasia, or an adenoma, particularly the inflammatory variant. This was diagnosed as a rapid enhancing hemangioma. Another type of hemangioma is a giant cavernous hemangioma. These are usually heterogeneous in appearance. They can have central thrombosis, therefore large portions of it may not fill in. There's fibrosis and calcification as well. Now, I told you that hemangiomas are a quote-unquote do not touch lesion. We don't want to biopsy it because we do make the diagnosis on imaging. There is one caveat, however. Some hemangiomas can have atypical features, and this can cause diagnostic confusion. So here you see this lesion on arterial phase of imaging that has this peripheral rim enhancement. You can see a lot of perfusional changes in the surrounding parenchyma. On portal venous phase, you can see progressive enhancement of this lesion, and it looks quite big. It's not nodular in terms of enhancement. And so your differential diagnosis here is cholangiocarcinoma, a hypovascular metastasis, or a sclerosing hemangioma. In this case, stability is critical. So if you have prior imaging that shows a hemangioma in this place and now it's changing to look like this, you may say it's a sclerosed hemangioma. However, if you don't have a prior study, this is a lesion that you definitely want to biopsy to prove that it's not underlying malignancy. And in this case, this was biopsied and this was a sclerosing hemangioma. Here's a 74-year-old patient, T2 hyperintense lesion. On T1 pre-contrast, the lesion is hypointense. This has peripheral enhancement, rim and not nodular, although there may be a focal area of nodular enhancement, kind of filling in. The reader said, well, this is a 74-year-old. I don't have a prior study. Yes, there is no underlying liver disease, but I'm a little worried about this lesion. So this was biopsied, and it was a sclerosed hemangioma. Let's look at this unknown real-life case. 62-year-old with abdominal pain presents with an echogenic avascular lesion within the liver, and this was interpreted as malignancy not excluded, recommend MRI. The patient ended up having a CT where you can see this hypo-enhancing lesion with a nodular area of enhancement. The patient also had this large mass-like appearance in the pelvis, which was an enlarged prostate gland, but it was dictated as a bladder mass. So this reader felt that this could be a metastatic lesion to the liver and recommended an MRI. The patient ended up having an MRI, and you can see on our dynamic post-contrast or multiphasic images, progressive nodular enhancement, light bulb breva on T2. So at this point, this really should have been diagnosed with a hemangioma. Move on, nothing further needed. However, the reader recommended biopsy. Echogenic mass again, avascular. This was biopsied, and it was a biopsy-proven hemangioma. So here is a case which is a classic appearance of a hemangioma on all forms of imaging at every time point. However, the patient went for a biopsy, and so again, just stressing that you really don't need a biopsy for these lesions. So in conclusion, we can use non-invasive methods to diagnose a liver mass with patients' clinical history. Specifically, do they or do they not have chronic hepatocellular disease or other form or malignancy elsewhere? We can use lab tests, and we can use imaging. Understanding imaging characteristics on dynamic post-contrast cross-sectional imaging is essential to accurately characterize lesions and can help to prevent unnecessary biopsies. Thank you.